New York City's public hospitals have a long and honorable history of serving those unable to access private health care. Today we will focus on how they came into existence and whether they still have a place in the modern scheme of things. I'm David R. Jones, President and CEO of the Community Service Society, a not-for-profit organization that seeks solutions to problems affecting the poor. We have as our guest on the Urban Agenda Sandra Opdycke, author of the recently published book, No One Was Turned Away, The Role of Public Hospitals in New York City Since 1900. Besides her scholarly writings, Dr. Opdycke serves as an adjunct professor of urban studies at Vassar College and an associate director of the Fordham Institute for Innovation in Social Policy. Welcome, Doctor.
Thank you very much.
Tell us a little bit about the book. What led you to start to look at this?
Well, I started being interested in hospitals really from the perspective of urban history. It seems to me that the hospital is a wonderful stage on which you see played out all the dramas of city life. Sometimes you see hospital histories more as medical history, like what were the diseases that got cured and so on. But the thing that's so interesting to me is that all the pulsing, all the immigration, all the changes in the economy, all of that shows up in hospitals. That's how I came to it first. And then the second thing was that I'm very interested in the whole question of social connectedness. And I think that sometimes we're losing the social glue that ties us together as a society. And I got very interested in public institutions as part of that story.
Well, what led the city at that time, of the turn of the century basically, to have to create the first public hospital?
Well, actually, the first public hospital is much earlier. Bellevue traces its ancestry back to 1736, where it started as 6 beds upstairs in the almshouse, actually where City Hall stands now. And that is really the very first medical facility. New York Hospital, a private hospital, was founded shortly thereafter. And then most of the big hospitals we know today in the city were established during the 19th century, between 1800 and 1900. So really from the very beginning, we had this parallel public and private system. But at every generation, what tended to happen was that the private hospitals served the community in the ways that they felt they could, and that whatever task didn't get done by those private hospitals would then be handled by the public system.
So faced with the immigration, for instance, of Jews, the Irish and the Italians, most of those individuals, as they came into the country, were served by the public system.
A larger number, but one of the things that's interesting that is a little different then from now is that as late as 1900, most private hospitals, just like most public hospitals, were serving mainly poor people for free.
Okay.
Now, that we don't think of that as a tradition now, but the situation then was that medicine was shaky enough and low-tech enough so that if you had a pretty nice house, you could actually be cared for just as well at home. In fact, I love the ad that New York Hospital used when they opened in 1877. They had opened a building on 15th Street, and their slogan was, "Surgery as safe as in the finest home."
I don't think many people would go with that now.
Not anymore. So it was really, it's as late as 1900, in a way the public and private hospitals were still serving a kind of common mission, free care to the poor.
Right.
It was really between then and say 1930 that the private hospitals began to change their mission.
And how did they do that? What happened?
What they did was they began to define themselves as kind of temples of medical science. And this became an appeal that drew in many more of the middle class and upper class. There were more specialists, more lab work, more technical machinery, and so on. And so when they did that, then they began to cut back somewhat on charity care. They still served some poor people, especially the ones that would help with teaching. Teaching patients. Right. But that wasn't their primary mission anymore. They weren't there to provide free care to the poor anymore. Okay. That mission then remained really pretty much with the public system. And so really from about 1920 on, you see the public and private hospitals sort of taking different roads.
So basically, when the Great Depression hit particularly, there was a sharp cutback in the number of poor people.
Yes, this really highlighted the change because this initial kind of redefinition that I'm talking about, less charity care, more middle and upper class people coming in, most of that really took hold in the 1920s. And as you know, the 1920s were pretty good times.
Right.
So it didn't show quite so much. And in fact, you'd often hear private hospitals saying, well, it's not really that we're serving less poor, it's just that there are less poor. They like to pay. You know, by this time, even ward patients in private hospitals were being asked to pay something.
Right.
But then, so then the question would be, okay, what happens when bad times come? And the answer was, when bad times came, the private hospitals kept on cutting back on their charity care. They actually closed ward beds, some hospitals. You can understand why they did it. They felt they were in a bind. They weren't getting the fees from private patients that they'd been getting. They weren't getting the big donations they'd been getting. The endowment income wasn't worth anything. And so they made the decision they felt they had to make. But the decision they felt they had to make was to cut back on charity care. So the effect was that there was this bigger demand for free care than ever before, less of it being provided in the private hospitals. And that's when the public hospitals really rose to the challenge and did this extraordinary performance during the Depression that really, I think, carried the city through that terrible time.
And I remember from your book, you put particular stress on the role of city government in encouraging that.
Yes, it was Mayor LaGuardia had this vision of the place of public hospitals in the life of the city. And he felt that they were just vital to what it meant to be a New Yorker, to the quality of life for ordinary, average New Yorkers. And he really begged, borrowed, and stole to keep those hospitals going in hard times. He exempted them from a lot of cuts that he made in other departments. When he could give raises, he gave them the biggest raises. He gave them a very talented, somewhat abrasive Commissioner Goldwater, and stuck by him all through the very hard times. And in a way, that was the secret weapon for the public hospitals. That was part of why they were able to do what they did. The other way that they did what they did is they spent about half as much per patient day as the private hospitals, so that they took these dollars that LaGuardia was able to give them and they stretched every dollar as far as it could go, and they put, you know, 50 beds on a ward. They just felt they couldn't say no, whereas the private hospitals felt when they got to a certain point they could say no. In fact, very early, right after the crash, there was a group of doctors in the public system who went to the commissioner and said, look, we're drowning. Private hospitals aren't taking the people. They're coming in through the windows. We can't handle it. Gotta limit daily admissions. And the commissioner said, treatment cannot be denied in the public hospitals for reasons of limitations on time or space. And that became really the guiding principle of the public system all through the Depression. And it was a vital contribution to the well-being of the city.
It's interesting you say, I mean, even today I talk to many audiences and they don't realize that the voluntary hospital, when we talk about private here, we're talking about not-for-profits.
That's right.
But they are only required to provide stabilization care.
Exactly.
In other words, if you're seriously injured in an auto accident, they just have to stabilize you. If you don't have cash, they are not obligated, though they do, and they do expend a lot on charity care, they're not obligated to see you.
I think that may be the key distinction. Nobody faults the wonderful job that private hospitals do for the patients they admit. The distinction is that in terms of serving the whole public, they don't have to. They may choose to, and when they do a wonderful job, but they don't have to. It's the public system that has to. I love that quote from Robert Frost that I sometimes use when he's defining home, and I always think that the public hospitals are to some extent everybody's last bet home, and he says home is where, when you have to go there, they have to take you in. And for New Yorkers, the public hospitals are their home.
It's also interesting. Obviously, we've gone through an ideological revolution in the city and the nation now, and clearly questions are being raised as to whether the public sector should get involved in certain areas they are. And our mayor and other people in the city have certainly raised the question around public hospitals. The mayor has publicly gone on record saying he doesn't believe that the city should be involved in public hospital support. It's interesting, what in terms of the historical view would this mean in your view? What happens if the public hospital system doesn't exist? Where do we go from there?
I think it would be a great loss to the city. In my book, No One Was Turned Away, I follow kind of as a case study. I follow Bellevue and New York Hospital, which is a big voluntary hospital, through 100 years. Here you have big private teaching hospital just actually 2 miles north of Bellevue on the same East River. And what you see in every era, in Bellevue and New York Hospital and in the two systems, is that there are always people that the public system, that the private hospitals don't feel they can serve. And sometimes it's issues of space, sometimes it's issues of money, sometimes it's who the people are, their race, their diagnosis, their prognosis, their behavior. But every era, there have been people that didn't find a welcome in the private system. And I find it hard to believe that that won't be true in the future. So I think that we're giving up a safety net that we've made very good use of in the past, and that would be a mistake.
We're clearly seeing something that's unique. I think clearly the very thing you talked about in the 1920s, that times seemed so good for some, that the notion of having a safety net in public health doesn't seem to be on everyone's radar screen. But we are seeing some trends that are giving sort of do-gooders like us some real pause. The incredible increase in the number of uninsured people by 39% or something since 1995 alone. And literally, we haven't hit the new welfare reform time limits yet for everybody. We're also concerned, and this gets back to some of the things you came out with in your book, about the fact that the Congress, in its wisdom, decided to specifically knock immigrants, legal immigrants, not undocumented, away from any health care support other than the stabilization kind of emergency care. So if you have an acute asthmatic condition or you have renal failure, you need to be on dialysis, that's not necessarily covered under the new welfare law. And those haven't really hit yet. No,
it's absolutely true. And in fact, we're living in a time right now when private insurers have been squeezing costs tight enough so that Medicaid patients look almost as good. And so we're actually in a period right now where private hospitals are serving relatively high numbers of Medicaid patients, higher than they did in the past. And so if you pick this moment, you say, look, they're serving lots of Medicaid patients, therefore maybe we don't need public hospitals. But that leaves out all the people who aren't covered by Medicaid, and what happens next week or next month or next year if Medicaid funding isn't as generous as it is today. So that everything is up for grabs. The whole fact that the legislature is debating what they want to do about subsidies for charity care. Suppose those melt away or are cut in half. What will the private hospitals do then? We don't know. And as long as we don't, it would be very risky, I think, to part with this system that has served us so well for so long.
One of the things that I've been working at this issue for years, and I didn't realize how artificially low they've kept eligibility for Medicaid. I was stunned. As many of the audience may know, even if you lose your welfare benefit, you're allowed to continue if you meet the criterion on Medicaid, but your income has to be, I think it's $13,000 or less for a family of four. If most people, working people, the working poor, dealing with even a minor surgical procedure would be homeless. Given
it's true. It's interesting. I was talking the other night to a guy who works at Bellevue, a staff employee at Bellevue, and I was quoting somebody who said to me about Bellevue in the Depression, and he said, I saw everybody at Bellevue, everybody was poor. And this man said to me, you know, it's almost like that now because so many different kinds of people are losing their health insurance. He said, there used to be a kind of a Bellevue look, you know. He said, that's just not the case anymore. You see so many people who have white-collar jobs, well-paid, blue-collar jobs maybe, but they don't have health insurance.
We sort of recite over and over again the case that came to the attention of my social work and other staff, direct service, of an immigrant, working immigrant, who had the misfortune of being caught in a crossfire in Washington Heights and literally ended up with a bullet in his hand, and he went to a voluntary hospital. They irrigated the wound with saline solution and they put a Band-Aid on it, and he said, you better get that looked at.
But not here.
Not here. And I was just outraged. The normal reaction, and it really goes down the issue that the voluntaries, the private sector has. I talked to some doctor friends. We ultimately helped this individual, and others did as well, to get to a municipal hospital to take the wound and remove the bullet and do all of the other things that anyone would think was natural. And talking to some of my doctor friends, they said, yes, that could happen. Said there may have been a real fear that there was nerve damage in that hand, and beginning treatment on that could end up, particularly with a person who had no ability to pay vast amounts of money, in literally tens to hundreds of thousands of dollars in unreimbursed care, because there's a bad debt and charity pool, but everyone knows it only pays 26 cents on the dollar. So what should we be saying to both those who are doing better, who have insurance, and who are political leadership, about why this public system should be allowed to sustain itself? Why we should put money back in rather than, we need help here to convince others. What is the story, at least drawn from your look, in terms of what we should be saying to everybody?
I think there are a couple of things. I think one thing is that the private hospitals never have done the whole job. They have not shown the inclination to do the whole job. In fact, I think many of them have been very happy to have the public system there to do the parts that they don't do. And there is no reason to think that if the public hospital system vanished tomorrow, they would suddenly start doing it. There's just, history tells us that's not what's happened. There was an interesting study done a few years ago where they looked at 100 cities around the country, with and without public hospitals, because one of the things people say was, oh, well, if the public hospitals weren't there, then the private ones would do more. And what they found was they did do more, but not enough more to make up the difference. So that, in fact, the public hospitals did add a level of care for the uninsured that was never replaced if you didn't have them there. And I think that would be true for New York also. And of course, in doing this, New York doesn't just take care of the people it treats, it takes care of all of us. The public system has the level 1, I think virtually all the level 1 trauma centers. Right. We all go there when we get in serious trouble. It's the poison control for the whole city, so many services like this also. Plus, we don't want epidemics sweeping the city. Right. It's in our interest to have the whole city healthy.
Well, one of the interesting things is, I think if you ask just somebody walking down the street, is there any particular centers of excellence, really getting into your question, in the public hospital system, I think they would be hard-pressed. But in your review, have breakthroughs occurred in the public system?
Oh, that no question. You can start with the ambulance in 1869 if you want to.
They created it.
Bellevue invented the ambulance, yes. They had a young doctor who'd been a doctor in the Civil War. And he discovered if he put some planks in the back of a wagon and got people right back to the field hospital, he could take better care of them. So then he did something like that here in Bellevue. And within, 10 years, they had him in London and Paris. It swept the world, the idea of a hospital ambulance. But there have been, really historic medical breakthroughs in all through the years. Of course, Dickinson Richards won a Nobel Prize in medicine with his colleague Andre Cournot for the heart catheter, and other novel work. breakthrough work on drug-resistant TB in recent years.
Well, actually, you mentioned Commissioner Goldwater. Goldwater Memorial, the leading specialist in long-term care, came out of that. And one of my frustrations, I served on the board of Health and Hospitals Corporation for 5 years until I was removed by the mayor. I sued him a couple of times, so it was legitimate. But we were fighting on the issue of privatization. And in the course of the ideological war, I realized that not only was it a fight about, only the voluntary sector should serve, but actually demeaning the work of the public system.
It's true.
That wiping out the history and all the things that its workers have done at lower costs, actually, than the voluntary sector. I hadn't realized that.
It's true.
I don't think most people know, for instance, that the ordinary worker at the public system gets paid appreciably lower and has to work in less salutary conditions than their voluntary counterpart. So it's really a cheap date for the city. I wasn't able to win on that subject, but privatization is virtually dead at this point. And interesting, you mentioned how important the public system is to the voluntary sector now. There was a brief flurry of interest from voluntary hospitals, big ones, wonderful, illustrious ones, in taking over some aspects of the public system.
That's right.
Until they ran the numbers. And the very point you talked about in the Great Depression, when they run the numbers out, if they're forced to take patients no matter what, they can't run.
That's come up over and over. This is the first time it's the mayor himself argued, well, except for Mayor Koch's brief flirtation with it in the 80s, in 79. But for 100 years, off and on, somebody has said, why do we have two systems? But the people you never hear chiming in saying, let's get rid of the public system are the private hospitals, because for them it actually works very well. They do the good work that they do, and there's the public system to do the rest of it. They have not led the fight to close down public hospitals in general.
As a matter of fact, two of the sort of less solid voluntary hospitals are on the verge of bankruptcy, in part because they're sited in areas where they're getting a larger and larger portion of the uninsured and they can't turn them away. So it's interesting. What about the issue of the economic downturn and the likely effect on public hospital system, not only in New York, but across the nation? What are people going to do when this boom economy, which I'm sure will never end, suddenly hiccups?
I think it's a serious problem, and the 1930s I actually have a whole chapter on the 1930s and what went on there, and it does suggest that if people are not enormously generous in good times, they're not going to be more generous in bad times. And that those are the times above all where you need a public system that not just is funded to do it, but has that mission, has absorbed that mission, operates according to that mission. That's what they're for, that's what they know how to do. And I think it would be pretty scary to go into that. And the thing, for those of us who are interested in the whole issue of social welfare, the problem is it tends to go underground, so that mostly you don't see the effects of the mistake that you made. It's just that there's a lot of suffering out of sight, because when you don't have public facilities, you don't even see the need. One of the things public facilities do for us is say, here's the need, here's the people whose needs aren't being met by the private sector. Suppose there were no public schools, or you wouldn't even know who couldn't afford to go to private schools. And I think that's the danger if we didn't have those. That this becomes
totally underground.
Exactly.
Well, when the Community Service Society and its predecessor agencies were founded 150 years ago, I was not here, it was clear that the healthcare crisis in New York was just huge.
That's
I
right.
mean, one of the first things when we go through our archives is the need for public baths. We created the first public baths, and it was growing out of health conditions that were appalling in terms of sanitation. And public health concerns and special needs for disabled kids, all these things were pressing on the system.
And then all of those play out in the public hospital. There's a lovely line at one point where somebody said, Bellevue is the city's people fighting for their lives. And I think there's that marriage between public hospitals and public need all through the city's history. It is a mirror to the city's history and its needs, and we need that mirror.
Just the issue of managed care, the managed care revolution is sweeping through public hospitals and voluntary hospitals.
That's right.
Did you get any sense, or do you have any sense of what's going to happen with public hospitals against the managed care revolution?
It has been very tough so far. I don't know whether, because initially the effect was really to draw, especially when Medicaid managed care, to draw patients away from the public system who were the only paying patients they had, and of course that was a tremendous financial cost. Then HHC tried its own managed care, but it really wasn't able to compete effectively. What the future will be, I don't know, but certainly the trend is a squeeze and a constraint that I would think would just make everything more difficult.
Have you seen any models anywhere else in the nation where people are grappling with this problem any better than New York?
No, I see them struggling with the same issues. I do think, obviously, LA came close to losing its public system in '95, and the federal government came up with, I think it was $35 million to help, help do that, which I think, again, is a tribute that however we talk about we don't need public institutions. If we really come close to losing them, we realize we can't live without them. But I see everybody struggling with these issues.
Were there any ideas that seemed to come out of how we're going to fund this? I mean, clearly, well, no social conservative. One of the critical problems is, where do you find the resources to fund these kinds of systems? Historically, I assume the government has to step in, but I don't, clearly we don't have that kind of shared vision yet in the city of New York or the state of New York as to how we're going to handle it.
I know it, and I do think that it has to do with choices. In other words, even in years when we have a surplus, that isn't where the city chose to put its surplus. In fact, the city, as you know, spends very little on HHC at the current time anyway. So they would not, of the expenditures the city now makes, I would think that would not be the most extravagant thing they could do, would be to make a larger investment in the people's health, and I can't think of a better investment.
Thank you. Thank you very much,
Yes,
Dr.
indeed.
Opdycke. You can get her book, Sandra's book, No One Was Turned Away, The Role of Public Hospitals in New York City Since 1900, at Amazon.com if you're computer literate, or Barnes & Noble, both their website and many of their stores. If you're interested in public hospitals and where the city is going in the not too distant future, it's a good jumping off point. There's a real schism between the city administration's desire to privatize or shutter public hospitals and the need to provide medical care for a growing population of the uninsured. The number of patients who do not have insurance has risen by 39% since 1995. Left untreated, these patients obviously will suffer, and they also are a threat to the entire well-being of the city through way of infectious disease and just quality of life. Additionally, the public hospitals bill will rise dramatically as they increasingly use public hospital emergency rooms for routine care. Rather than destroy a public hospital system that has worked for over 100 years, we need to strengthen and streamline the existing structure so that it can continue to serve the poor and uninsured. This is David R. Jones. Thanks for tuning in to the Urban Agenda.
To comment on the Urban Agenda or for more information on CSS, contact Community Service Society of New York, 105 East 22nd Street, New York, New York, 10010. Area code 212-254-8900.